three great colleagues and some cases and some interaction, which we hope to illustrate the use of this relatively new technology, which has really changed the way in which we treat calcified lesions. So we've got Holger Nef from Marburg, we've got Marek Ferenc from Bad Göttingen, and we've got Tom Johnson from Bristol. And we're going to talk about some cases. We're going to show the technology in action, and then we can discuss perhaps how this technology has broadened a little bit the cases that we can treat, but perhaps more importantly, improve the results that we can expect to get. And I think that's really one of the important messages, and perhaps improve the safety for our patients too. So with that, I'm going to turn to Holger, if I may. Holger, you're going to talk to us about rocks in hard places, principle of lithotripsy, current IVL data, and indications in calcified coronary lesions. Thank you very much for joining us, and we look forward to your talk.
Dear Chairman, thank you for the invitation to present at the EBC 2021. The title of my presentation is Principle of IVL, Current IVL Data, and Indications in Calcified Coronary Lesions. Regarding the stent-oriented goals after PCI, the efficient stent delivery is essential. Thus, we have learned also from intravascular imaging that a good mechanical results can be achieved when MSA is greater than 80 or 90% with an absolute MSA greater than 5.5 square millimeter. If dissection is not present, plaque burden at the edge and malposition should also be avoided. Well, from several studies, we know that an adequate stent implantation can reduce clinical events and, of course, symptoms on the one hand side, but also often results during lesion preparation, which is mandatory to achieve such a good results in procedural complication. So balloons have an insufficient force to crack calcium, often results in barotrauma or balloon rupture. Also, atheroablative strategy are also limited by a wire bias, only potentially resulting in slow flow situation or even perforation. Taking this into account, intravascular lithotripsy has been introduced, especially in lesions where calcium angle is more than 180 degrees and calcium thickness is more than 0.5 millimeter. Additional consideration using IVL are vessel with a lesion and a large residual lumen more than 2 millimeters, or ortho-osteal lesions, or of course, bifurcations. The intravascular lithotripsy comes with a balloon catheter and a generator. The generator produces energy which are applied by the emitters in the balloon catheter. A small electrical discharge at the emitters vaporizes the fluid within the balloon to create rapidly expanding bubbles that generates the sonic pressure waves and then collapses within a few microseconds. When wave impact the calcium at nearly 50 atmosphere, they create a series of microfractures and then makes the vessel more compliant. Here you can see the effect of lithotripsy either in OCT, you can see the microfractures, or in IVUS. In the latest data coming from the CAD III trial, IVL showed a high safety endpoint. The primary endpoint, which was freedom from MATE within 30 days, was observed in 92.2%. The lower confidence boundary of 89.9% meets the performance goal. Here you can see the clinical endpoints, which were rather low. However, there was a high success rate after treatment with IVL. Finally, I want to show a clinical case which shows a severe calcified lesion, which is nicely demonstrated in the intravascular imaging, which was OCT in the right coronary artery. And IVL treatment was then applied. here in the severe calcified lesion, which results in a high compliance of the former stenosed vessel. So the IVL treatment leads to better vessel compliance after creating the microfractures, resulting in inadequate stent expansion. So therefore, I like to conclude adequate stent deployment following after optimal lesion preparation is mandatory for better clinical outcomes. Conventional strategies in severe coronary calcification might be insufficient, and therefore intravascular lithotripsy offers an alternative treatment to ensure optimal stent deployment, thereby demonstrating efficacy and safety. Thank you very much.
Opportunity to discuss these presentations shortly, but we're going to take the next presentation from Marek, who is live, I think, in Brussels. And Marek's going to talk to us about rocks in hard places, advantages of IVL for optimal lethal preparation in calcified coronary bifurcation lesions. Hi, Marek, good to see you.
Yeah, good to see you. Thank you. And really, I'm only one from this group here in Brussels. So, yeah, we have to treat in many cases also calcified coronary bifurcation lesions. And as you can see here, according to our data from more than 2,100 patients with coronary bifurcation lesions from our registry data, we will find in up to 5% really severe calcified coronary lesions. And if you follow such patients up to 3 years, you will find in every third patient the need for TLR and including MACE. So the lesion preparation is extremely crucial. So you can go ahead with standard balloons. You can use cutting or scoring balloons. They are, of course, also a bit bulky, but if you go by standard approach, you can use 2 wires and you can have 2 wires in position. If you have to prepare lesion with the bulking technical approach like rotablation or orbital atherectomy, the point is very clear. Then you have to remove at least remove 1 wire, so you have only 1 wire in position. And again, if you start such debulking approach, lesion preparation with a shockwave balloon, with IVL, we have a definitely advantage to have 2 wires in position. And please always, if you see such very difficult anatomy, then there is a very clear need for difficult recrossing. You have to go sometimes from retrograde approach, and as you can see here in this LAD circ bifurcation lesions, and if you try this a few times, you can even lose side branch or even damage completely the patient. So always, if you use this all staff like Svenek guide or supercross macrocatheter with difficult side branch access, please think 2 wires in position will be very useful. And if you have to go with, let's say, orbital or rotablator, you have to remove 1 wire. If you go with prodilatation with shockwave balloon, after you prepare the lesion with 1.5 or better 2.0 balloon, just to make a channel for a shockwave balloon, then you will be on the safest way, and you have here both vessels wired. And sometimes there is a guiding extension needed. So then you can go with, usually you start with 1 balloon, a shockwave balloon for the main branch or larger branch, and can exchange to the side branch, or you take second one. And after this lesion preparation, you can use even all these technical strategies. And this is just an example for this. This is the left main after rota shockwave treatment. And this is a case which I present, severe calcification in LAD. And what we want to achieve, as Holger just nicely showed, these fractures in the plaque, and also to achieve really good stent expansion. And this is a case of the LAD and diagonal branch lesion, which we recorded with IVL. And the problem was here, there was initially the idea the first diagonal branch is really large. However, it was a bit smaller than the second one, and according to the complete revascularization, we went ahead here with lesion preparation. You will see now very soon this complex bifurcation lesion. There are 3 diagonal branches. The first one is subtotal and calcified, severe calcified lesion. So it was not possible to go with OCT catheter, so it was needed to prepare the lesion. Finally, we have done this and saw this picture, this movie of this critical segment of LAD, and it was clear we have to go here with the bulking technical approach. And because of this angulation to the first diagonal branch, we decided to go here with shockwave balloon. Here you can see 8 times we could give energy here. And this is now again a view with fractures, as we could see before in Holger's speech. And finally, we could go with stent ahead. It was a Dickey crash. Postulated distally, make it final keys, final pot. And you can see this patient was finally treated by IVL, double stenting, and checked by OCT. We put it one more stent in proximal area because of some dissection, and now you can see in final shot the final result. And this was, I think, very acceptable result. Really not huge first diagonal branch, but according to this distal LAD, which was also stenosed, I think now all side branches are perfectly open. So this is a final shot. And so in coronary bifurcation lesions, IVL is really feasible and safe due to 2 wires position. So you have a permanent wire position in the main branch and side branch. In some cases, you have to perform rotor shock or orbital shock approach, and imaging is definitely very helpful. And I think Tom will show us in next presentation the importance of imaging. Thank you.
Thanks, Marek. That was great. And it's really interesting looking at the result angiographically that you got in that case. And I would contend it probably couldn't get that result without this shockwave technology. It really was an extraordinary result in the main vessel. Because one of the things about rotablation, obviously, is it gives you a channel, but it doesn't necessarily, well, we know it doesn't disrupt the adventitial and medial calcification in the same way as this technology. Tom, you're going to talk to us about imaging, rocks in hard places, the role of imaging in calcified bifurcations. Thank you very much. We look forward to your talk.
Dear Chairman, thank you for the kind invitation to present at this year's EBC. My presentation is entitled Rocks in Hard Places, the Role of Imaging in Calcified Bifurcation. The objective of my presentation is to define where imaging fits in an algorithmic approach, the criteria we may use to guide intervention, real-world experience, where perhaps qualitative calcium characterization will further advance our decision-making, and the role of imaging in planning and mitigating the challenges of treating rocks in hard places. There's data out there to highlight the significance of both presence of calcification and bifurcation, which are closely associated. And here we see from the Mount Sinai group a very high rate of periprocedural myocardial infarction, particularly in the combined presence of calcification and bifurcation. They used relatively high rates of rotational atherectomy, almost 50% in this cohort, but it must be criticized that actually imaging use was relatively rare, with less than 10% being guided by IVUS or OCT. It's therefore gratifying to see in the most contemporary algorithmic approach by Margaret McIntaggart and James Spratt that imaging plays a very central role in decision-making. And why is that? Well, we know from this rather elegant series looking at patient cohort who had angiography and IVUS and OCT, that angiography identifies calcium in just less than half of patients, where OCT, and then actually IVUS best of all, identifies a much more significant cohort. When it comes to comparing IVUS and OCT, actually they're fairly well matched in terms of assessment of calcium angle. Obviously, OCT has the potential for assessing calcific thickness, although reverberation artifact by IVUS may be a surrogate of that. Why is that important? Well, there's data out to show that where we have an arc exceeding 180 degrees, a thickness of more than 500 micron, and an extension over more than 5 millimeters, that we can very accurately predict stent under expansion. In this validation, we see that 30% of stents fail to achieve a 70% expansion, where all three of these criteria are met. There's been some very elegant work done by the Light Lab initiative looking at the impact of OCT in 12 centers in the States. Must be acknowledged that it seems that direct stenting is often used in the United States, and so as a consequence, OCT identifying calcium resulted in a change in decision making in almost a half of patients, either taking a compliant or non-compliant balloon, but then also advancing your decision to use of a cutting or a scoring balloon in a quarter and taking atherectomy or laser in a further 25%. Where no change in device was made, actually the majority were having fairly aggressive strategies deployed anyhow. But we saw overall an uptick in the use of aggressive calcium modification from 3% to over a quarter, 27%. In our practice in Bristol, actually across 4 years, we've seen an interesting increase in intravascular imaging in orange here with rotational atherectomy. You see a drop in volume in 2019, and that was due to the receipt of IVL in 2018, where we took a departmental strategy to use imaging in the vast majority of our cases. And now you can see that in over 80% of all of our calcium modification cases, we are reliant upon imaging in both detailing the extent, but also ensuring adequate modification and optimization of our stent result. Beyond that, I think there is a role for the need to characterize calcium, and here very beautifully shown in a cohort of over 1,200 ACS patients, we see that there are a number of different types of calcium that we may have to treat. Superficial calcific sheet, eruptive calcified nodule, calcified protrusion, and it may be that we need to use different adjunctive technology or combinations of adjunctive technology when faced with this type of calcium. So my personal approach is an image-guided one. Where uncrossable, I'll be using rotablation. Where we see evidence of significant burden of calcification according to the criteria I've identified, then firstly, actually, I'll palpate with a non-compliant balloon. But if there's failure to yield, and if the imaging shows calcified protrusion, then I'll look to debulk. In the presence of more circumferential calcium, then I'll turn to IVL for the purpose of fracture with further imaging to identify effective modification. Let me show you a case. This is a 71-year-old with stable angina, but symptoms persisting despite optimal medical therapy. Right coronary is dominant and relatively free of disease. Circumflex has some mid-vessel disease, which is FFR negative. And then we see in this cranial projection really very significant and extensive disease of the LAD, affecting a large first diagonal branch and also a septal branch more distally. We took a decision to treat the proximal bifurcation by complex 2 stent and provisional approach to the septal LAD complex more distally. So pre-dilatation and then imaging of both limbs, and here I show you the OCT of the diagonal, which shows rather elegantly sparing of the carina as we'd expect pathophysiologically, with calcium in the diagonal that may only need further palpation. But in the LAD, we see circumferential calcification over very extensive length and more thick than 500 micron. And so immediately take IVL with delivery of 40 pulses, and importantly by OCT show very significant fracture and modification. So embark upon stenting distally with a 2.5 by 28, stenting into the diagonal with, again, a DK Calotte technique. So proximal optimization, again, with a 3-5 balloon, OCT confirmation of wire passage into the LAD, kissing, followed by then the proximal LAD stent. Now, interestingly, the OCT actually shows that the stent inadvertently extends back into the left main, but fortunately, we've taken a 3-5 device that will expand to 5 millimeters in that left main stem to achieve stent apposition. And here we see the final result with gratifyingly fantastic stent coverage at the level of the complex D1 LAD bifurcation, expansion of our stent to 5 millimeters in the left main, and an MSA in that proximal segment where we had high-grade calcification of 10.2. So in summary, rocks in hard places, they associate bifurcation and calcification, associate and are related to poor outcome. It's essential we recognize calcification to ensure good result. Imaging is better than angiography, and we now have criteria that we must use to ensure we avoid stent underexpansion. IVL is a fantastic disruptive technology, and we must be seeking to avoid acute stent underexpansion to avoid late stent failure and achieve best outcome for our patients. I thank you for your attention.
That was great. Thanks, Tom. So there's a question from our online audience. Perhaps I could ask you this, Holger. What's the role of lithotripsy when you haven't got 180 degrees of calcium? Do you think the technology is still likely to be effective or not?
Well, we have looked at the patients on the CAD I and CAD II patients cohort, where we have differentiate between between an eccentric and an eccentric lesion below 180 degree in some cases, and as well as in the concentric, we showed that IVL is also effective in the eccentric lesion, and this is somehow I would also recommend. However, in some cases you do not need the IVL, of course, when the calcification is below 180 degrees, but you can be sure that you have also the effect if you use IVL in eccentric lesions, as it is also effective in concentric lesions. What we did not know so far is how to treat calcified nodules, as showed by Tom in his talk, and I don't believe that we have the right tool so far available for the calcified nodule. Maybe it's orbital atherectomy. However, IVL also in this kind of lesions is not working very well.
That's certainly my understanding about the nodule as well. I'm not sure we really have the right tool. I think one of the things that we tend to, as interventional cardiologists, we think about the lesion, and we sort of consider there's going to be 3 millimeters of concentric calcium, and that's the only bit we're going to treat. And one of the comments that you made, which I enjoyed, is how lithotripsy changes the compliance of the vessel throughout the length that you treat. And it actually then makes the stent delivery and easier, and then your ultimate stent expansion easier. And it's the whole vessel that you end up treating, because ultimately, quite commonly in rotablation, it's not the little bit where the calcium was on the angiogram where the burr starts to really bite. It's further down. The whole vessel is always very calcified, isn't it? And this is a way really of treating the whole vessel, which is ultimately what the patient wants. I would ask, perhaps Marek, what's been your experience with perforation? Do you think that we're making these procedures safer using lithotripsy?
Definitely. We do a lot of cases in bad crossing, so usually more than 3,000 a year. So I saw in the last 10 years only one perforation and bifurcation lesion. So we could manage this by a covered stent. Very, very low rate of possible complications using IVL. And from my perspective, it's really very simple tool also in smaller hospitals where doctors are not extremely skilled in rotablation and orbital atherectomy. Using IVL, they can even go to distal left main to bifurcation lesions. So complications like slow flow or even some problems with rhythm are very, very seldom. So from my perspective, we have now one more tool in our hands to manage calcified bifurcation lesions in a better way and safer
well,
way.
we won't forget that the IVL balloon is also ruptured sometimes, and even in very calcified lesions. So I have also experienced sometimes that the balloon is ruptured. Well, this has to keep in mind that, well, in some cases you have to go for the rod ablation, of course, and the balloon is not the right tool.
Yes, we've certainly seen that. Finally, Tom, if you were treating a calcified bifurcation, would you routinely then lithotripsy both the LED and diagonal? Would you use the balloon in both branches straight away, or would you be differential about that?
I would be entirely guided by the imaging, I have to say, Adrian, which I think is the approach that we've now adopted, having, with the arrival of IVL, institutionally agreed that we would increase our imaging use. And actually that's just led to a more intellectual kind of process as to how we should be treating it. And Marek highlights it's another tool. It's been the most instrumental tool, but it is one of a number that we probably have to institute. And so I struggle a bit when you see on social media and you hear others talking about this is the answer. It's made a stepwise change to what we can do, but it has to be seen amongst the other technologies. And so I think you have to be guided by what we see. And unfortunately, the angiogram doesn't tell us much of what we're really trying to treat. So my message, I'm afraid, is a kind of ongoing one, which is you use the imaging to guide the therapy. So just because I've taken the balloon won't mean I'll then use it down both limbs. I'll use it where I see concentric calcification or a heavy burden of calcium that's going to impact on my stent expansion.
That's very clear and very useful. I mean, I think that's been a fantastic overview of our joint experience with lithotripsy. I think it offers, very commonly, we had to treat this challenging calcific disease with inappropriate tools or inadequate tools, more accurately. But I think we now do have this expanded armamentarium. And I think it has led to a real stepwise improvement in the sort of results we can get. And my sense is it's also making things safer. And clearly that's important to everybody, and particularly our patients. So with that, I'd like to thank Holger, Marek, and Tom for their participation, and for our colleagues online, and hand you back to the rest of the EBC 2021. Thank you very much.